and atherogenic risk, a case-based discussion. 2 points I would like to make as a preamble. One is that there is a U-shaped association between HDL cholesterol and all-cause mortality among this study, this population of 42,000, where they saw that if the HDL cholesterol is less than 30 or it is more than 70, the risk of mortality increases. The second point I wanted to make is the chameleon-like nature of HDL. In the non-inflammatory state, anti-inflammatory proteins are associated with HDL, and HDL promotes cholesterol efflux, inhibits reactive oxygen species production, and increases nitric oxide production. Whereas in the inflammatory state, pro-inflammatory proteins are associated with HDL like serum amyloid A, and here it exactly has the opposite actions. Coming to my case, this is Mr. K, 69 years old gentleman, non-smoker, teetotaler, exercises regularly, no relevant family history of premature coronary artery disease. In September 2009, he had infeval MI, and he received an RCA stent, which was a bare metal stent. He has been on antiplatelets, beta blockers, ACE inhibitors, and high-intensity statins with therapeutic lifestyle changes. Somehow he reduced his statin doses early in 2017, and the same year, sometime in July, he reported to the hospital with chest discomfort. Clinical examination was normal, troponins were elevated. The ECG showed new onset of a left bundle branch block. He was admitted for coronary angiogram. The left system showed non-obstructive coronary artery disease in LAD and diagonal. RCA showed proximal block, and you could see that arrow pointing the stent which was placed in distal RCA. The lesion was crossed with a wire. It was stented, and he had the in-stent restenosis that was also addressed by deploying another overlapping stent with good results. Now let us look at the possible risk factors which could have led to this recurrence of cardiovascular event. Now, before the first event, if you look at his LDL cholesterol is 107 milligram per deciliter, and HDL was 26 milligram. With high-intensity statin treatment and other usual glycan-directed medical therapy, LDL cholesterol came down to 49 milligram per deciliter. HDL cholesterol remained at 26 milligram per deciliter. Now, before the second event, when he had reduced his statin, his LDL cholesterol has gone up to 76 milligram per deciliter. HDL is 22 milligram per deciliter. Again, we intensify his lipid lowering treatment, and his LDL has remained at 49 milligram per deciliter and HDL at 24. So these are lipid targets recommended by LAI. In this very high risk group, his LDL cholesterol should be less than 50 milligram and non-HDL should be less than 80 milligram. Now we tried to look at the other residual risk pathways. His LPA was 15 milligram per deciliter. His high sensitive CRP was normal. His HbA1c was 5.6. His, of course, ejection fraction was normal, and his GLS was slightly reduced, minus 16%. So the notable features are LDL cholesterol and non-HDL cholesterol were not at target before the recurrence, and he had persistently low LDL-HDL cholesterol. The inverse association between plasma HDL cholesterol and the risk of ASCVD, among the most consistent reproducible associations in observational epidemiology. Now, 1 milligram increase in HDL will reduce the risk of CHD by 2 to 3%. In contrast, of course, Mendelian randomization studies do not provide compelling evidence that HDL is causally associated with the risk of ASCVD. Furthermore, there is no evidence from randomized trials that therapeutically increasing plasma HDL cholesterol reduces the risk of cardiovascular events. If you look at the total cardiovascular disease risk assessment systems across the globe, all of them have included HDL cholesterol or low HDL cholesterol as one of the high-risk features. Low HDL meaning less than 40 in men and less than 50 in women. However, if you look at the key contemporary HDL risk pathways, you don't find low HDL as a residual risk factor. Now, there are a number of causes for low HDL causes, genetic and secondary causes. We should diligently exclude the secondary causes. These are elevated triglycerides like end-stage renal disease, hypothyroidism, obesity and overweight, pre-diabetes and diabetes, physical inactivity, smoking, very high carbohydrate intake, metabolic syndrome, drugs such as beta blockers, anabolic steroids, and progesterone agents, and probucol. And there are some other unusual causes, like there's a paradoxical lowering in some patients with fibroids, as reported from some workers from this city, and artifactual low HDL cholesterol with paraproteinemias. Now, there are certain therapeutic interventions which will increase HDL cholesterol: smoking cessation, weight reduction, physical exercise, statins, all will increase the HDL cholesterol. Fibrates, niacin, CETP inhibitors of co-increase, but we have no cardiovascular outcome of benefit. ApoA infusions, there have been studies which have shown that these infusions result in atherosclerotic regression, but these are small studies. We need larger study and of longer duration. Now, there are one or two studies which I have taken which might help our clinical practice. Now, this is one study of about 24,000 coronary heart disease-free participants who were followed up for more than 10 years. And what it showed, LDL cholesterol and triglyceride modestly predicted CHD risk in black and white adults. Low HDL cholesterol levels were detrimental only in white adults. High HDL cholesterol levels were not protective in either race. Then coming to this study, the SMART study, where 6,000 patients who had vascular events or established vascular disease were studied. And what was found was the HDL cholesterol levels are related to the risk of new cardiovascular events only in those patients with clinically manifest vascular disease treated with usual lipid lowering therapy, but not in those patients treated with intensive lipid lowering medication. So if somebody is receiving intensive lipid lowering therapy, low HDL cholesterol does not matter. So most of us probably at this juncture would like to take the shelter of this editorial comment which said the praetor does not concern himself with trifles. Means don't worry about HDL cholesterol, worry about, concentrate on achieving the target of LDL cholesterol, non-HDL cholesterol, and of course along with the intensive lifestyle modification. Please remember, when you talk non-HDL cholesterol, we have already indirectly incorporated HDL cholesterol. Now, coming back to the case, the recurrence of cardiovascular event in this patient is probably explained by LDL cholesterol and non-HDL cholesterol not being a target in the presence of low HDL cholesterol. Unfortunately, we have no drugs to offer to raise HDL cholesterol which will benefit. He has been advised to continue aggressive therapeutic lifestyle interventions, high-intensity statin therapy, and regular follow-up, and await new developments in the field. Highlights of this HDL cholesterol: HDL has multiple atheroprotective properties like cholesterol efflux, antioxidant, anti-inflammatory, anti-apoptotic. A low HDL cholesterol is often associated with unhealthy lifestyle and is a marker of the disease. HDL particle concentration and HDL functionality are probably the better metrics, and we need better redefine the HDL metrics. The treatment of HDL associated risk is an evolving area. Focus on LDL cholesterol, non-HDL cholesterol, and in selected patients, ApoB. Thank you.